and it's an undisputed pleasure to be back in Zermatt. What we present now is the Airway Wednesday, and it's a collaboration between our airway management laboratory and cutting edge and course in Copenhagen, Friis Tvede, and the Big Sick. And we develop stepwise each year, and we have new things for you. We are this group, many of you here actually helping with the workshop. This is highly interactive. Friis Tvede is a co-arranger, also back home at the Airway course. We develop all the ideas together, and we've got several for this time. And he's also head of the HIMS medical part of the HIMS service in Sjælland. And we have got Søren Rudolph, the same, developed several of the techniques we published on, we can tell about today, and is the trauma manager at Rigshospitalet in Copenhagen. Myself, Michael, very early in my career, I decided one of the most ugly situations is actually to put a patient to sleep and not being able to oxygenate him so that he dies or get brain damage. It's such an ugly situation. I have been in a situation where afterwards I should explain to the only son that his mother, fairly young and a dancer, had got permanent brain damage due to airway management that retrospectively could have been done better. And I don't want any of us to experience that. And since we have been and we are constantly working on trying to improve this for ourselves and for us and for our customers, our patients. This is Rigshospitalet Copenhagen. You can see you are welcome even at night. You just land there, and we have coffee on the machine, and we have got all kind of exciting things to offer. We have this is one of our prizes, the yearly course, Airway Management for Anesthesiology, and we got this webpage, airwaymanagement.dk, and that's important because several of the references will be obtainable there, and the videos and material that you can use freely for your own education and for your peers. And we like international participants there. And actually what we do, we take the highlights and bring them to Zermatt, and then we get inspiration and make new highlights. So it's a constantly developing process. We also, as course material for our course, we wrote this book together with 62 experts from around the world in airway management. It covers 95% of what you want to know about airway management. And the last 4% you get tonight, if you want. And then there's one that we are still working on, and there will be more to come, of course. I have to admit, Danes and ski, that's challenging because we are very, very flat country, and here we have the highest point in mainland Denmark is 180 meters. But look at this. This is in Copenhagen, Denmark. This is the world's most advanced power plant where we burn the waste, and we make a lot of waste in Copenhagen. We turn it into green energy, and on top of it, we installed a ski slope. This is the view from the top. It's wonderful. You can see, you can get up there, and one of the best things is actually the after-ski bar, because you got a nice view of Copenhagen up there. This is a setting sun, and this is my son and me trying to snowboard down there. But we have a hidden gem as well, part of the Danish kingdom, Greenland. The northern hemisphere's largest glacier. It's 2,000 kilometers long, and we have a lot of ice there, and that becomes more and more valuable these days, as you know. And there, actually, we have other means of transportation. This is a local hunter and myself, dog sleighing to the northernmost natural habitat village in the whole world, smoking a cigar. This is I'll never forget this patient because his name was Perry, so he was a grandchild of Perry, who actually discovered the North Pole. So they didn't only spread inspiration, but also their genes up there. And these are some of the local drivers. This is a Danish mountain. It's an iceberg, got stuck in the fjord. And I looked at it for 3 days, and then I decided, is it possible to ski an iceberg? And I can tell you it is, but it's a surprise. It's like an ice cube. So it's not snow, it's hard ice underneath. So you have to have very sharp edges down there. Okay. So we are so lucky we have several guests. We have Chris Root from neighboring state to Texas, where they also have mountains, and we want to visit him there. And we have Rasmus Hesselfeldt from our own department, also involved in all the developments, and he will also be part of the lectures. We have John Daniels from Geneva, who will show you very, very interesting new ventilatory aspects together with me. We got Tatjana Dill from Switzerland showing ultrasound of the airway, and then we got Pims from the Netherlands, we've got Hilda, we got Luca, we've got Gergely also from Geneva, Jelse here from Switzerland, Trond from Norway, he's a very good skier. Oh, we don't like it, the Danes, but he is. And we got Maria from Bulgaria, we've got Mike, and we've got Willem Jan, and we've got Kristen, and we've got Nels Petter. And you're gonna meet all these nice people later at the workshop. And we'll take discussion after the whole session, because maybe some of the questions will be answered or be even more complicated. So we'll take them afterwards, and then the leftover questions during the hands-on workshop, where we'll be available for 3 hours, and you can just enjoy what you want. So we want to be able to manage, for instance, a patient like this. He's a difficult airway. He had surgery some hours ago, and there he was difficult. He needed an awake intubation. Now he's in the post-anesthesia recovery. He's bleeding like this, and he needs redo surgery. So before you leave, you'll be able to manage this guy and many, many others, guys like him. So we'll talk about airway management. What is it? Why should that be important? About plan prediction, combination, and special circumstances. What is it? It keeps being fascinating. This tiny piece of anatomy from the tip of the mouth until distal trachea has to stay open all life. If it's closed more than a few minutes, brain dead is 2 more minutes, death. This is my son. The moment you cut the nature's ventilator, the umbilical cord, from there on, it has to stay open, and part of it is our responsibility. There are exceptions, of course. If you're on an ECMO machine or you have your head in ice water, then you can do a few more minutes. And the very interesting, it's our responsibility. You in here, 2/3 of you are in specialties, or maybe even 80%. We read the list of participants where this is our responsibility. We cannot call on a surgeon or something else. We need to be able to fix the situation. This is the best study ever on airway management on complications. It's old. It's already 12 years old. I'll just cite a very few things because 80% of it is still true. They had a 1-year data collection in the United Kingdom. They had this number of cases related to general anesthesia and 19 deaths, brain damages. And in the ICU, fewer cases, but a higher fraction of deaths and brain damage. And when these cases were analyzed in detail, and in 3/4 of the cases, there was actually poor management. And ICU and emergency is highly overrepresented here. And this is only the tip of the iceberg. This is absolute minimum numbers. The reality is more grave. And this is why it's worth being here. It's preventable in the majority of cases. We can prevent that to happen. What happened there? A failure to plan, and if they had made a plan, failure to follow the plan. And it's natural, we can all end up in that situation, but if we can try to avoid it. This is a much newer study, 2021. In TUBE study, 3,000 ITU patients intubated, and events occurring within the first half hour of the intubation procedure. You see 1 on 20 esophageal intubation, difficult intubation, aspiration, pneumothorax, pneumomediastinum, and front of neck airway management. So it still happens, and this is also the tip of the iceberg. No doubt this is underrepresented here. We have a lot of choices for managing the airway. We can either do nothing, let the patient breathe, give a bit of local anesthesia. We can supplement with a gas mixture with a lot of oxygen in it. We can put on a face mask. We can put the face mask down in the throat, then it's called a laryngeal mask airway. We can put it all down in the trachea, then it's called an endotracheal tube. Or we can put it via the front of the neck, then it's called a tracheostomy, a front of the neck airway. And we can cannulate the large vessels, and it's called ECMO. So, and this can combine. We can do this awake, anesthetized but still breathing, or anesthetized and apneic. And we can decide where we want to place our patient, what's best. We need to have a plan. I'll very brief walk you through algorithm that may sound very boring, but that's a framework for the new development. So we must have a plan, otherwise we go into the gray. This is a peak-to-peak gondola in Whisper. No, where was it? It's in Canada. So we need some plan prediction. And these are the new American guidelines. These are the Canadian guidelines. And we'll walk you through the Canadian guidelines because they are the best, the most well thought of. And again, if you download this as a PDF, you will have a very good textbook actually on airway management. Most important statement, prior to airway management, a documented strategy should be formulated for every patient based on airway evaluation. Airway evaluation, that can be done like this.
Prøv munden alt, hvad du kan.
Please open your mouth. Yes. Could I ask you kindly to stick out your tongue? Yes, please. And would you mind showing me your lower teeth? And would you mind bend your head backwards? And then I can measure the environmental distance. And that took 15 seconds. No excuse. Even in the semi-emergent situation, we can get some impression of what will be difficult here. And it has been disputed. Is it worth trying to predict? And it is worth trying to predict. At least half of difficult intubation can be predicted, and that is likely to be the obvious and most difficult patients that we can predict. So it's worth spending this 15 seconds, or at least have a look. And it also works for predicting when do we need awake intubation, when do we need to use a flexible scope, for instance. So it is worth. These are the Canadian guidelines. They start by the question, is tracheal intubation predicted to be difficult? And then there is a row of questions downwards. And if you answer no to all of these questions, then it's okay to give general anesthesia and give airways after the general anesthesia. So first question, is awake tracheal intubation absolutely necessary? And sometimes it is because there may be no mouth opening at all or other circumstances. Then, of course, we can answer yes and go to the right. And then the next question, will it be possible or difficult rather to do face mask or supraglottic airway ventilation? And if we say no to that, that will not be difficult, then we go on. This is about the prediction. And then we should look for adverse physiological questions. And that could be, for instance, especially decreased apnea tolerance, meaning that you don't have enough oxygen for a longer time. That could be decreased functional residual capacity, or even you start out being hypoxic, which is often the case with our patients. Or it could be a full stomach, or it could be a patient that is likely to hemodynamically crash if we give anesthesia. Next question, are there complicating contextual issues? And you'll get to hear more about that. It could be an adverse location, and it could be that we don't have help, and we are inexperienced, we lack equipment, and we don't know our team. For instance, sometimes we end up working in a hospital where they don't even speak our languages, and it could be poor communication. And then there's one important consideration that's actually missing, even though it's the best airway guide, one is missing. And there's one point where the Americans are smarter than the Canadians. That is the question, will a frontal neck airway access be difficult? Because that has to come in here, and you see actually ASA, the Americans, in this particular, they remember to include this. But if we combine them, we get the best guidance. And predictions of difficult frontal neck airway access, you see I put it in parentheses because after today, it'll be easy for you to predict because you'll learn how to use ultrasound to see where is the cricothyroid membrane or where is the trachea. Okay, and if we answer no to that, then we can put the patient to sleep and intubate or mask ventilate or whatever we want. If we can answer yes to some of these questions, then we should think about, could the patient cooperate to awake intubation, and is there time for awake intubation? Why on earth is that interesting? We'll come back to that. And that could be either awake tracheal intubation, or it could be awake tracheostomy, awake frontal neck airway access. Awake, why is a good idea? Because the airway is preserved, the patent airway is preserved, we don't have to make it. Spontaneous breathing is preserved, we don't have to force oxygen in there. It's easier to identify the glottic opening if actually bubbles are coming up from the trachea, and then the patient can help us. For instance, if you say, would you kindly protrude your tongue? He can do so. Or would you kindly protrude your lower jaw? He can do so as well, and that gives us more space. he can be sitting up, and there are several other advantages for this. We can observe his neurological status, for instance, if he has a cervical fracture. So there are many advantages linked with awake intubation. If we keep the patient breathing, but he's unconscious, then we can only say yes to the first 3 questions. He cannot corroborate, and the rest will be a no. And if we give the patient full anesthesia and or neuromuscular blockade, then we can say no to all of the questions. So that's why awake is such a good idea. So we go on with this flowchart. If we can say no to this, the patient cannot collaborate, or there's no time for it, then we can do this, have a airway double setup, which is highly relevant also in some traumatic patient, for instance. That consists of, we identify the marking of the cricoside membrane before we give anesthesia. And if we can't palpate it, we use ultrasound. We decide who should do the actual access of the airway. We ensure we have equipment there, and we decide beforehand what will be the trigger, which physiological parameter to reach when we do this. And then we can do the airway double setup, and then we can give anesthesia. We give a lot of oxygen, first of all, and then we can give anesthesia, and often it will work. If it doesn't, we are totally ready for the emergency frontal neck airway. This is when we can predict difficulty. What I show you is about when we have some prediction. Then in the other setup, we already have an unconscious patient. Either he was brought to us by Zermatt, or we find him on the street, or somebody puts him to sleep. But now the patient is already conscious, so it's another situation. Then and we can't readily intubate. So then the question is, can we ventilate, of course, with a mask or a supraglottic airway? And if we say yes, we have time, we can do additional attempts. And then if we still have a ventilation unproblematic, then we can consider an exit strategy that could be awaken the patient or put a supraglottic airway and continue with the procedure. If we say no to these questions, we cannot ventilate, then we over here in the cannot ventilate, they call it cannot oxygenate situation. And then if the patient is currently or imminently hypoxic, then while we prepare for the front neck airway access, we can do one more attempt at securing the airway with laryngoscopy or supraglottic airway, or what we want. And if that's successful, we have won some time. If it's unsuccessful, then it's about the front of neck airway access. And all of you who want it will have the opportunity to try on a nice mannequin to do front of neck airway access after you have learned to find the cricoside membrane with ultrasonography later tonight. And you can even drink beer together with it. Okay, so that's a framework that we work within. Now we'll have a look at some special techniques. We have so many choices. There keeps coming new choices, and it seems that every Chinese who has a factory that can make something, or plastic makes a new laryngoscope, for instance. So we are flooded with it. But we'll show you that even if you have to live without the advanced equipment, without these nice things, then you can still, even this little, you can still do advanced airway management. And we'll show you 2 techniques that you'll also be able to practice during the workshop, because this may come in handy if you work in a remote place, if you go to Greenland without bringing equipment, if we end up in a I'll tell you later, an African hospital. So we would like a method that is simple, that is only demands cheap single-use equipment, that can be applied in awake or anesthetized patients, that can be applied even in bloody airways, and that works for all on nasal intubation, and that allows easy reintubation if necessary. We would like that. We've got it, and before the evening has turned into night, you will all be able to do it. We need this equipment. We need an epidural catheter. We need an IV cannula, and we need a tube. And this is a luxury version. If you also have a forceps or some lubrication, some local anesthesia, it's really a luxury, but it's not strictly necessary. This is retrograde intubation. And there are several techniques published for this. The smartest and the cheapest is this one called pulling instead of guiding, meaning that, and I have several videos of this, but I'll show that later on in the presentation. So what we do is that we penetrate the anterior neck. We put in an epidural catheter through the anterior neck, let it come out the mouth, and then when the epidural catheter came out the mouth, we'll make half a knot in the tube like this, and then we can pull the tube down past the tongue, past the pharynx, into the trachea. And once we pulled it until the tracheal wall, we stop pulling and we push, and then the tube goes into the trachea in the majority of cases. I'll show you later in a real case. Okay, another cheap and useful technique is called the tube tip in pharynx, and I like very much this introduction. This is Port Harcourt up in the Guinea Bay in Africa. One of our nurse anesthetists on a Sunday morning, she was in this hospital with Médecins Sans Frontières, and she sent me this email many years ago and says something like this: "Dear Michael, you have indirectly contributed to saving the life of one of my patients tonight here in Africa because you taught me the TTIP technique. So we will share it with you as well, because this is smart. And it's a simple single-handed, and it requires definitely minimal equipment. So what we do is that you pull the jaw forward, and then we introduce the tube about 10 to 12 centimeters. We inflate the cuff, and then we close the nose and mouth and pull the jaw forward, and then we ventilate. This is a classic technique. The even simpler technique is when you just take the hand from the caudal end and close the mouth and nose like that. This is a very tiny nurse anesthetist and a very big patient, and actually with failed ventilation, and it was saved there. It looks like this. The nurse just had it demonstrated. This patient is asleep. Pull the jaw forward, introduce the tube, and fill the cuff with about 20 milliliters of air, and then attach either your self-inflating bag or the anesthesia system and close the mouth and nose and pull the jaw forward and ventilate. It looks like this, and that could be in the stomach, but this is a luxury situation. We have the waveform capnography as well. And we have several publications now on this, and it keeps amazing, at least me. Then we can combine techniques. And Rasmus, please tell us some obvious combination.
Thank you very much, Michael. It is indeed a great honor to be here in Zermatt together with you guys and the TBS team. I've been looking forward to this. And we're going to talk about a bit about the combined techniques. And to set this scene or the frame for this, allow me just to have you, all of you, close your eyes for a minute. Just close your eyes. Inhale. And now you're all anesthetists. It's your dream come true. You're all anesthetists, okay? For the next couple of minutes, you're all, okay? But the thing is, it's 2:30 in the morning, and you're called to the OR, so maybe not a dream come true anyway. So you're there, you rush to the OR, and you walk in, and what you see, they're doing a grade 1.5 cesarean section. There's a registrar or colleague there. That's not very good. The BMI of 43. They tried DL, they tried VL a couple of times. They changed to hyperangulated blade. The patient is quite good rammed. Muscle relaxation is in. Everything is good. DSATs still, and they placed an IGL. And they're quite happy with it. And they called you to the situation. And the obstetrician is like, guys, we need to move forward. But you have this. The capnography is okay, but it's not perfect. Sats are 86. It's not good. And this list, what's this? Is this aspiration? Is a little bit of vomit coming out from the attempt of bag mask ventilation attempts? So that could be a situation. I don't know what you would have done. But now we're going to talk about intubation supraglottic airway device. So this is what we're going to do, okay? So combined techniques. So I'm going to show you a video in a minute. And I know that you got various equipment for this intubation through a supraglottic airway device where you come from. The smart thing about this technique is that you can ventilate throughout almost all the procedure. So I know there's an entry catheter, which many of you got for this same procedure. But yeah, just let me show you this video of how you can do it with ventilation going on at the same time. Hopefully this will work. So this could be an IGL as well. Anything. Pretty standard thing. You confirm. Yeah. Waveform. Capnography. Coming there. Happy. So they disconnected. They insert the tube. Half a distance, approximately. And you need to lubricate, obviously. Yeah. Always lubrication. Always lubrication. And inflate the cuff. You put on the adapter with the bronchoscopy connection. And you start the ventilator. Okay? Pretty simple. But the difference is that you're ventilating the patient now. Okay? You didn't disconnect it and start putting in your flexible scope. You're ventilating the patient now on the ventilator. And you can cut a hole in the membrane. That's fine. If you got a slim scope, you might not need it. If it's very well lubricated, you might not need it. She's doing it. And you'll need an assistant to hold that tube still and maybe straighten it out a bit, even more than this. Hopefully you'll be in the right spot. I've seen the video before. Yeah. Okay, in goes the scope. You see the carina. Everyone's happy. You're breathing normally again. Yeah, you deflate the cuff. It's important. Yeah. And actually, you can see, of course, the waveform is not as perfect as it was before, but the patient is still getting air. Okay? Take it out, put it on, and confirm. Okay. Oh, good. So you might see a difference between this situation and the situation I was trying to paint in your inner picture before. So this is quite a few steps, so it will need training. How many of you have trained this in elective cases? Hands up. Yeah. And the thing is, you might be training it, but your assistant needs training as well. So you all remember the intubation, the ILMA, the intubation laryngeal mask, that needed some adaptation, some muscle memory as well. And this will do as well. It's quite simple and it's doable, it is effective, but it's rare and it needs training. Okay? You're still an anesthetist, so you go back to your room, you go to sleep, but it's 4:30 in the morning, and you're called to the ED. Ah, the ED. So the emergency physician says, "Oh, you might come down here." And he says, "Oh, is there an airway you can't handle?" I said, "No." "Oh, really? But you might want to see this before you take this patient to OR in a minute." Okay. So we go down there, and we see this patient. I said, "Yeah, looks pretty awful. The patient needs OR surgery for severe bowel obstruction." Okay, so it needs to go to OR. Surgeon says, "Yeah, no doubt." And you want to do this awake, okay? Anyone who's just want to put this patient to sleep? No. No one that's saying yes. Okay, maybe there's a bit of local anesthesia on the front of the neck here. I can see that already. But anyway, so I say, yeah, no worries. I'll just go through the nose. And the surgeon says, no, there's severe pathology up there. And so we got some trouble with our normal awake, flexible intubation procedure. And I'm going to show you a simple technique, which is quite correlated to what Michael just explained to you before. So we will see a video of the combined tube tip in pharynx with the flexible scope intubation. Here we go. Combined techniques. Pictures of that before. Should be here, yeah.
Så vær venlig at åbne munden så meget du kan. Jeg ved godt, det kun er en centimeter. Og
Det kan måske føles lidt sært.
stik tungen lidt frem. Den er god. Sådan, og så må du godt glide lidt sammen om den. Sætter lige den her på. Sådan. Og så kigger vi stille og roligt ned og ser, hvordan det ser ud på spidsen.
Skal du tage kamera på maskinen også? Skal du tage kamera på?
Det skal lige præcis. Du har fuldstændig ret. Godt, Martin. Det skal vi nemlig. Det var lige det der. I aftale. Godt. Tak for det.
For at åbne munden en
Lille smule mere, ja. Det er jeg følsom for. Nå, det ikke. Sådan der. Så prøver jeg at holde der, så prøver jeg lige at blæse kosten op, så jeg giver det lidt
And
fast.
as with the supraglottic, it might not be perfect
Det spænder lidt
positioned
i munden.
at
Prøv at
the
se, om du
first
kan lade være med
attempt,
at bide i den,
so you might
Tak for
need
det.
to reposition.
Sådan, prøv at se, du og hen til den, kommer ud, så prøv at trække den lidt tilbage.
And we just published a paper on the supraglottic intubation thing, and I've watched 100 intubation through that, and it's not as easy as it looked before. But here we go. This is quite easy. Yeah. And this is a patient with normal anatomy in the hypopharynx. Yeah.
Så lige hosten en gang, kan du det? Ja, tak skal du have. Kan du det? Ja, tak skal du have. Det er fordi, jeg kigger linsen. Prøv at se, hvor smukt det er med venstren der, var. Prøv at se, hvor smukt det er med perfekt. Intet mindre end perfekt det her. 100%. Intet mindre end perfekt det her. Eller retter sådan lidt over, så du er vant til.
And if you haven't seen this before, see how close the thyroid membrane is with the cannula is to the vocal cords. You see that? Okay. Deflation, important again. Insert the tube.
Jeg har tømt koffen, og så jeg har tømt koffen. Så bliver ikke at stoppe skubet for langt. Det bliver ikke at stoppe. Du kan også få mig til at avancere. Mens du trækker, du kan også få mig til at avancere. Mens du trækker det der, så avancerer jeg, og du holder. Og du trækker der, ja, og du trækker det.
All right. So,
Og en gang til.
tube goes in, but the thing is here, this is very simple topicalization as however you do it in your normal standard procedure for your patients to be tolerated, intubated, awake, can be effective. And this might be rare, but I mean, there's a lot of people with radiation therapy to their jaw or mouth going through other kinds of procedures where you might need this technique, okay? So wherever you are practicing. All right, cool. I'll hand this back to Michael now, and thank you very much for your attention.
Thank you, Rasmus. And the good thing, you will all be able to try this guided by Rasmus and some of the other instructors in a few hours, in 1.5 hours up there. So we'll keep combining and we'll keep using techniques in combination. What if the case is that we look into the mouth, for instance, with a flexible scope, and we can't find the little hole in the big hole being the mouth and the pharynx, the little hole being the entrance to the airway. And No, now that it could be here, or it could be here. We don't know it. And it could also be covered with by blood. Wouldn't it be nice if it was flashing towards us like this? Who would like that? or who wouldn't? Yes, we would like that. Good thing is that it's now possible. And you will all try this at the workshop as well, because we use this technique. This is a lady for awake intubation. She's got nasal oxygen. We identify a cricothyroid membrane. We place a small emitter of infrared light between 700 and 1,000 nanometers. That will push this invisible light to the cricothyroid membrane. We give local anesthesia as usual for awake intubation. We prepare some more local anesthesia with a flexible scope. And then we start this one. And we introduce the flexible scope via the mouth. And where we normally look for something black, meaning the trachea, we now look for some flashing light, if it works. So we got a lot of sputum here, but we have given glycoparylate, and then we would like to see some flashing light that will show us where to go. This is a uvula. That's not what we want. This is epiglottis, and there we got it. So you see it from below the vocal cords. You go towards it, and you go. Yeah, you advance the scope until you are in, of course, until you're in the mid or lower part of the trachea. You see it coming in through the cricothyroid membrane like this. And you go down till you see the carina, and the rest is, of course, business as usual. So she didn't have really severe pathology, she just had narrow space. What about real severe pathology with tumors in there? That's where we really need it. And we go via the mouth, the pharynx, and we look at this mess. Look here. The patient is awake, of course. He got some local anesthesia, but it's a bit difficult to see where to go. We would like some, oh, did you see it? We would like a hint of flashing. Is it over there? No, it's not flashing. It's light, but not flashing. Ah, there we got it. Let's move around the corner. Let's go beyond the false cords and beyond the true cords. We see the cricothyroid membrane from the inside, and the rest is procedure as usual. So I like this case. It was a case where the surgeon presented the patient for us, and they do a pre-anesthetic nasendoscopy, and they wrote inability to visualize the vocal cords due to pronounced swelling. They tried, they couldn't see anything on the other side. We'll use the infrared light, so we did. Okay, but does this work in clinical daily practice, or is it only exotic? So we actually just 23 published a randomized comparative study where we took patients for all awake intubation with a flexible scope, and we mimicked it as much to the daily clinical situation. So it was even trainees who were appointed to that room that did the intubation, because we want to see if it works in daily practice. What we did is that we did 2 insertions in each patient. One, we had a randomized crossover design. One was with the infrared first and then no infrared. The other was with no infrared and then infrared. And the primary endpoint was at which point in the airway could you see a sure guidance of where to go, either the vocal cords or the flashing lights. And we had 44 insertions in 22 patients. And the red one is the infrared flashing light. You see, in some cases, already up in the mouth, or in the majority case, in the oropharynx, you could actually see the flashing light and start going for it. Whereas without, you had to go to the tip of the epiglottis or to the original level to see it. And it was also faster. And yeah, this is the ease, subjective reported ease by the anesthesiologist. So we conclude that it is easier to identify the airway, and we can do it higher up in the airway with a higher success rate there. Okay, further combinations and special circumstances. Michael Friis Tvede and Søren Rudolph, please.
Thank you, Michael. As Michael told you, we looked at all the participants here, and my God, it is a really daunting task to give a talk on pre-hospital airway management to this crowd. There's so much experience in here. We stood here last year and talked about pre-hospital airway management, and we stumbled upon a bit of controversy because we spoke about in-cabin intubation. We thought that it was, well, this is something new, this is something that we need to try. And our message was more or less that you need to think about your practice. And it sparkled so much discussion afterwards. So we really came back to the point that we need to look at this further. So this is what we're going to do. So we took a look at the literature and we learned a bit. We didn't learn everything, but we learned a lot. So what we want to do today with this short lecture, and especially afterwards, we want to share some of the thoughts we have on doing confined airway space management. And we really want to learn from you guys. You have so much experience. So going back to the Canadian guidelines, as Michael said, these are, in my perspective, the best guidelines. And if you think about pre-hospital airway management, there's one sentence in here that actually encapsulates what is the essence of pre-hospital airway management. And the question is, are there any complicating contextual issues that might impact the decision? But it's not really a question, it's more like a statement. There are complicating contextual issues that will impact the decisions on airway management. This is the essence of pre-hospital airway management. And confined spaces is a really, really major contextual issue. So if you look at the literature, there is not a lot, and most of the literatures are done in mannequins. And we won't put any references up, but we've combined with, this is, you can all take this IR code, and then you can find the lists of publications that we've found. So please do that, and some of you might find some of your own publications in here, and thank you so much for letting us use those publications. All right, so first of all, what is a confined space? You all know this reference, which says something about your age. Obviously, when you don't have enough space, that's a giveaway, dead giveaway. But also, if you have too much of something else. And what would that something else be? We'll take a look at that. So your traditional thought about a confined space, this is a confined space. This is a confined space. This is a confined space. And you actually also have problems getting in and getting out here. There's light temperature. Some of you work in conditions like this. And you have difficulties with both access, extrication, and a chaotic scene. A lot of noise, a lot of stimuli where you need to take your decisions. And if we don't have a patient in a confined space, we will certainly bring a confined space to the patient. This is our helicopter, the EC135. You see here, nice patient, not a lot of room if you want to do airway management inside this cabin. This is another one. This is not our helicopter. This is the helicopter Jeltse works in. This is the standard confined airway, a confined space on wheels, a standard Danish ambulance. And you can have pretty good room. This is the 138, the Airbus or AW138. You have pretty good room here, but then you place the stretcher in a pretty awkward situation and you close the doors. Then you have really, really bad airway access here. The modern ICU, great for patient care, bad for airway management. You need to do some manipulation of your environment here. And we have larger and larger ORs, but we tend to fill them with robots, equipment, surgeons, a lot of surgeons, and we tend to create our own confined airways, confined spaces within those ORs, even though they are very big. And obviously, sometimes we encounter patients that will maybe make that space confined, even if it wasn't confined to start with. So, what should we do? Sadly, there is no single technique that can be used in any setting. But depending on situations, there will be specific devices that may be of advantages. Well-known devices or techniques that you already know may be used in alternative ways, or you may adopt another way of accessing the airway. And when we look at this, we think you should actually think about this in a way that, is it a controlled or an uncontrolled environment? And Michael, you will talk about the controlled environment to start with.
Thank you, Søren. This is me in a helicopter, our helicopter EC135, as Søren said. This was actually my first attempt of in-cabin, in-flight intubation, which kind of set this discussion, began or initiated our discussion about in-cabin, in-flight intubation, and now confined space intubation. It's a CPR, cardiac arrest scenario. Patient is resuscitated with a laryngeal mask. It worked quite well for some time, but he began to be cooperating, and I decided to take out the laryngeal mask and intubate with a video laryngoscope. It was absolutely uneventful. It went very well, but it's not something we do every day, which the look of the paramedic kind of shows here. I'm happy. The patient is satisfied, giving me a thumbs up. And we fly on. This was, as I said, the beginning of our discussion about in-flight intubation. I'm not very sure that it's something that we should recommend, because there is it may cause trouble for ourselves, but at least in-cabin intubation is something worth considering, because, for instance, this study that we conducted, the first article from the FASTER group showed in 422 drug-assisted pre-hospital intubation, showed that the first pass success was rather high, and that the situations where in-cabin intubation was done caused a shorter on-scene time, which we believe is important for patient outcome. Doesn't show that in-cabin is superior, but neither inferior. You should know your environment. You should train in your environment. You should know your equipment, and you should have everything readily available when you try to do in-cabin intubation. This is our kit dump from the helicopter. It's checked every morning, and it gives us everything needed besides drugs. I believe that it's one of the key issues for doing successful in-cabin and especially in-flight intubation, that everything is where you expect it to be. Changing helicopter, changing environment makes it more complicated, and there is examples that when a service gets a new helicopter, suddenly their time consumption is much higher because everything is different. And talking about everything being different, these are two of my colleagues, Thomas and Stine. They are both consultants. And obviously, it's another situation for Stine in a helicopter and from Thomas in a helicopter. And actually, Søren and I discussed that some things may be easier for me, being not that tall, easier for me than it is for Søren. I don't know if that should alter our decisions, but at least it should make us, we should be aware of the differences, and it may influence our decision. And now for the uncontrolled environment. Thank you.
Okay. So everything that you do in the controlled environment, everything you do as part of your standard practice is now you need to manipulate this when you encounter the uncontrolled environment. So the first thing that you do is when you encounter something, you need to size up the scene. Size up the OR, size up the ER, size up the room you enter. What are the considerations you need to focus on? Well, first of all, your own safety. And it's especially in pre-hospital care, but what is your own safety? What is the patient's safety? And what are the immediate patient needs? And how do I get in and how do I get out? And how can I manipulate that environment to do as safe airway management as possible? And really, if we should recommend anything, we recommend don't intubate in a confined space. But if you do have to do it, these are some of the things you can manipulate, some of the things you have to consider. There are special devices, there are special techniques, there are the position of the rescuer and the position of the patient. But you need to consider these things and train them in advance. All right, so what can we recommend? Well, we can recommend using a supraglottic device. In every study, mannequin studies and also clinical studies, if you compare time to effective ventilation, supraglottics will win every single time. So sticking in a supraglottic, extricate the patient, that would be my first recommendation for pre-hospital airway management in confined spaces. And you can see, as in this instance, I think it's a British picture, and it's an older picture sticking in the intubating LMA. I don't know, are any of you still using intubation LMAs pre-hospitally? Yes, but it's more or less just disappeared for some years. If you do want to intubate, expect a higher failure rate, expect longer times. And it really doesn't depend whether you use DL or VL, and all the different types of VL that you can get, it will take you longer time, it will fail more often. And you do have to train this. Familiarity with your kit dump, as Michael said, familiarity with the environment you work in is a plus. You need to train. Having really good stand operation procedures will make it easier to manipulate your equipment, know your equipment. And these are the channel devices. The AirTrack, the KingVision, the GlideScope, the CMAC all provide devices with a channel for the tube. And most anesthesiologists really don't like these because it ties you down. But maybe there is a place for this in confined airway space management, and I'll come back to that later. Also, there might be use for the more special devices. This is the Viva site with the camera in the chip, and this is the light wand, very old device, but it might also be of use in confined airway. Again, an anti-recommendation is using the digital intubation. Very few studies, it's described as a forgotten art, but the only studies where they actually looked at this, very experienced providers considered this to be both unsafe and uncomfortable. So we should shy away from doing digital intubation if we can. Okay, so you've all seen a picture like this. Yes, inverse intubation, icepick intubation seems a good name for Zermatt. The tomahawk or the face-to-face. It really is, that's the same, it's the same technique where you will standing in front of the patient and you'll intubate them in this upside down position. And there are several studies looking at this inverse technique, both in simulated and retrospective cases. And you can do it either with this one being a direct laryngoscope, or you can use a VL. It's still difficult. And what is difficult that you turn everything around. What's left is right, what's up is now down. And you really don't have the normal axis and direct view of the vocal cords, which you would have in a normal intubation. So this is something really, really difficult. And just putting the laryngoscope in your right hand challenges your hand-eye coordination. So this is where the channel devices might be a good idea. So it sort of frees you up. You can insert it with your right hand, and it's the laryngoscope that actually delivers the tube. And you can push the tube in by yourself, or you can have an assistant putting in the tube for you. But this might be a good idea. So positioning of you as a rescuer. So much work have been done by our colleagues in France, and I've stole these very nice illustrations from one of the publications. And there are several different options of how you can position yourself. There's the lateral left and right position. There's the kneeling position. There's the sitting position, and the prone position, and there's the straddle position. But it all comes down to ergonomics. Whether you are able to straighten out this axis, get a good view of the cords. So whether you choose, whenever you choose, you have to train again, train. And you will expect a worse laryngoscopic view and less ease of intubation. But if you do have this one back here, but there are differences. The left lateral position is associated with better glottic exposure compared to the kneeling position, and you can apply greater force using the straddle position. And it sort of makes sense that if you're sitting behind the patient or kneeling behind the patient, you won't have that really, really good alignment of the airway axis as you would do being prone or in the lateral position. Again, put in a supraglottic, extricate the patient. So the patient is now stuck in a very awkward position. This has not been studied a lot, but there are several case stories about patients being intubated in different positions. This one is a case from Colombia, where this gentleman had a disagreement with another gentleman, and he placed a large knife in his neck. So he couldn't be on his back, and the anesthesiologist tubed him while prone, and he actually described that it was very easy because when the patient was anesthetized, everything tended to fall down and downwards, and it was actually very easy to intubate him in this position. I haven't tried this. Obviously, using a video device will make it easier, and I think in some ORs this is used as standard, and not having the patient put in prone position after anesthesia induced. And this is a lateral position. But again, the very few publications all describe worse laryngoscopy view and less ease of intubation. And last but not least, but not supported by any evidence, I think doing a front of neck access as your first attempt is actually a very good solution in many cases. So this is a very nice picture I borrowed from one of our colleagues in Denmark. Actually, the gentleman you saw in the picture with the very busted truck earlier. Okay. So again, to summarize, don't intubate patients in confined airway spaces. Stick in a supraglottic and extricate them. We'll talk about this a lot more tonight.
Thank you, Søren. Yeah, we're all gonna try later on. Special circumstances, back to this gentleman, bleeding and difficult airway at the same time. This same situation, bending forward, gravity pulls blood out of him, the surgeon trying to compress the bleeding, the anesthesiologist looking a bit thoughtful about what to do. This is the anesthesiologist. So we had to study literature, come up with recommendations on actually how to manage this bloody bleeding airway. It's also in the book. What is special here is that several of our favorite techniques that solve 98% of situations, they can be rendered useless due to the blood. So we are stuck with some basic or alternative choices. So of course, compress the bleeding site, position the patient. Often he needs to sit upright or even leaning forward. Be sure to suction all that you can, give oxygen all that you can. And remember food resuscitation, because if you give anesthesia, he may have bled a lot. And then evaluate the airway, and that includes identifying the cricothyroid membrane. And it's enough with the 15 seconds evaluation and the cricothyroid membrane. If we predict successful direct laryngoscopy and we can identify the cricothyroid membrane, then it's okay to go on with a rapid sequence induction. So this could be called the anatomically easy bleeding airway. And we get some help from Chris. There you are, right from New Mexico. Thank you for giving us advice on this. This will move forward, the green one.
Terrific. Okay, I'm going to take a page from Rasmus. Everyone close your eyes. Imagine you're in a picturesque mountain town at 1,500 meters elevation. There is a 3,000 meter peak just above. The air is cool and crisp. The food is delicious. You're in Albuquerque, New Mexico. That is where I live and work. It's near Texas. I'm not from Texas, you can tell because I'm unarmed. So Prior to moving to Albuquerque, New Mexico, I was a New York City paramedic for about 10 years. I attempted to intubate many people. Every now and then I did it successfully. I became very interested in how to manage the contaminated airway, the airway that's been soiled, because so many of the airways we encounter are full of stuff that we wish wasn't there, right? So raise your hand if you've ever had to manage a contaminated airway before. I presumed as much. Raise your hand if before the first time you had to manage a contaminated airway, you had received or you had practiced deliberately how to manage that airway in simulation. A lot less hands, but it's exciting that there are a number of hands up. So I met and got to teach with a gentleman named Jim DeCanto. He's a mad scientist who moonlights as an anesthesiologist. He developed a technique after tinkering with mannequins in his garage called the salad technique, suction-assisted laryngoscopy and airway decontamination. Are there? There might not be. Okay. Okay, we'll flick through the slides. Should I just?
We'll first take the situation. Okay. First, we'll take the situation where it's difficult, meaning that we predict we have difficulty with front of neck airway access. Why is that the case? It's because necks look like this and not like your necks. And this is one of the situations. This is Dagmar, who's going to have anesthesia. I look at her the day before, and I have no idea where might her cricothyroid membrane be. And if I needed to do an emergency airway access, should it be here or where should it be? Fortunately, we can use ultrasound to identify the cricothyroid membrane. And you see the structures here, and we have a stepwise approach that you'll all learn tonight. And we call it pearls on a string. The first one, you put the probe like this, and you identify the trachea in the midline. And then next step is that you slide the probe laterally so that you kind of truncate trachea in half. You rotate into the longitudinal position like this, and there you see black pearls on a white string. And that's the anterior part of the tracheal rings. And then you move cranially, you see the cricoid cartilage, you move further cranially, and there you see the thyroid cartilage. And then you can mark the longitudinal course of the airway like this. And then I need to ask, will you? Okay, so as we always have to improvise, as you know. Okay, so we found the longitudinal course of the trachea, and then we can find the place of the cricothyroid membrane by sliding this needle under the transducer and looking for the shadow cast by the ultrasound beam, and that's here, and then we make a cross, and this is the midpoint of the cricothyroid membrane. It looks like this in a difficult patient with short neck, previous radiation therapy, 1.8 centimeter mouth opening, and limited neck extension, difficult landmark palpation. And we do like this. We place a probe transversely. You see a tracheal ring. You go longitudinally, and we see this is the cricoid cartilage, and we see the tracheal rings. We mark the longitudinal course. We slide the needle underneath, and you can see the shadow from the needle coming there. And you mark again with a pen. And if you, in this case, we just confirm with the transverse technique, and you can learn both today. This is the Here you see the cricothyroids. You move up again, and you've seen the cricothyroid membrane there, and it's the same place. It's identified. He's awake. He's got nasal oxygen, and we want to give some local anesthesia before awake intubation. So we use our new information. Where's the cricothyroid membrane? We do a needle cricothyrotomy, like we also did in the previous video. We aspirate, and this is verification that we're actually in the right place, and we can give local anesthesia. And this is that on the day of surgery, we identify the cricothyroid membrane. You see it's very lateral on the neck, and you see it's confirmed by CT scan, but this is more useful information than a CT scan because it actually shows where is it on this specific patient in this specific moment. And we just made this study where we had a thick neck constructed where you couldn't palpate anything. And then we could have the airway deviated to one of the sides. Please open the MacBook. and then we could ask colleagues, consultants, in a randomized fashion to either palpate or use ultrasound. And with palpation, only 3.5% identify the cricothyroid membrane, whereas with ultrasound, after a very brief course, 3/3 actually were able to identify. So this leads us to the awake access when you have a predicted difficult airway. And we can do awake tracheostomy, and we can do one of all these techniques. Transillumination, you already saw it. Søren showed it from the inside. We showed it with the infrared. Intubation by supraglottic airway device that you will learn about today. And then cricothyrotomy, tracheostomy, and retrograde intubation. You already saw it presented, but this is how it looks in the bloody bleeding airway. This is a surgeon. She is quite tense. The patient is difficult. He's obese. He was difficult before, and he came in the emergency room bleeding. He needs surgery. He will be very difficult to do a tracheostomy on. He's sitting, gets nasal oxygen. He knows it's dangerous. He's very cooperative. There's nothing that motivates you like being in this situation. And just a minute. This should become a video showing how we identify the cricothyroid membrane with ultrasound. And just a minute. We go forward. And one more, this one. And we do the retrograde intubation. There it is, you see. It's a mess, but he's highly motivated. You see the cricothyroid membrane. And the surgeon never saw this before, but she's very grateful that we can help him. We put in some local anesthesia because we know that he might need an emergency cricothyrotomy. And then we have identified the cricothyroid membrane with ultrasound. We saw that. We do this. We do the needle cricothyrotomy as I showed you in elective setting. Now it is in emergency setting. We aspirate, confirm that we're actually in the airway. And then we take the epidural catheter. You'll all practice this technique this evening. You put it in. You take the natural curvature of the epidural catheter so that it goes cranially. The surgeon never saw the epidural catheter. I said, look for a plastic thing coming up. Help me pulling it out. She said, yes. She's very highly motivated. Otherwise, she has to go attack this neck. So she does as we say. There it is. She pulls it out, the epidural catheter. And he helps by spitting it out a bit. And again, highly motivated. There it comes. And now all we have to do is to make this half knot through the Murphy eye. And then we'll see which technique we use this time. We have of course worked on the cheek. And then you put the epidural catheter via the tube. And then once it's in place, we will switch to pulling the tube down, because then we don't need to see anything. We just go beyond all the blood and damaged tissue that we got there. And now, by pulling the distal end, I asked the patient, please stick out your tongue, and the surgeon keeps compressing the bleeding side. And yes, we pull down the tube until we encounter resistance. And when we encounter resistance, we stop pulling, because then we're on the inside of the cryogastric membrane. Then we start pushing instead. And there's no coughing because he already had a lot of blood, so he has had all the coughing that he did beforehand. And then you connect the ventilatory equipment, you see waveform capnography, and you can put the patient to sleep. So that's one of the methods that we can use in this bloody bleeding situation, and you'll all try it at the workshop later. Okay, and it's very cheap. Then another a special circumstance is if we have to manage the airway with, may I have your attention, please? You will all try it in the workshop. You don't have to discuss the technique now. If we have little or no device in the airway because it's so narrow, and why would we need that? It could be because this is Karen McGrady. She looks fairly normal, but this is how her airway looks. She has a very tight narrowing supraglottically. There's not even space for a tube size 40, so she needs this. This is Hanne. She looks very normal airway, but look what happens when we look into her mouth and beyond that. She has different pathologies, including chondrosarcoma. She needs various surgery. There's no space for tube, but not even probably not even for jet ventilation here. And this is Frank, and he has only a small pathology there in his airway, but he has a very severe pulmonary hypertension, so it's actually high risk putting him to sleep at all. So all these needs some alternative from a standard treatment. And it may be because we have limited space for airway management, limited space for surgery, or because we want to avoid general anesthesia. So how can we do this? We have several techniques, and all of these techniques have some pros and cons and advantages, and we'll look at a few of these. And a question is always, is this technique good enough for the patient, allowing suspension laryngoscopy, but because that will be necessary for much of the surgery here. And if you take a fully awake patient with local anesthesia, that could be Eric that we saw before, give him local anesthesia, do awake surgery with the flexible scope. So we can take a biopsy from this tumor, that's fine, but almost only with the flexible scope. Otherwise, the patient will not tolerate it. So with the awake patient, we cannot really do suspension laryngoscopy. How much can we see? This is a % of glottic opening, and 100% if we can see the whole thing. And with this, of course, we can see the whole thing. This does not allow balloon dilatation for stenosis. It allows us to vary the oxygen fraction if we want to use a laser. So we can use the HFNO, high flow nasal variable oxygen fraction. There will be CO2 elimination because the patient is breathing. It allows dynamic airway observation. So if we have the vocal cord pathology, or if we have a soft trachea, for instance, we can evaluate that. But it demands an open airway, and there's no cough, there's no protection against aspiration. Then, if we put the patient to sleep, but he's still breathing spontaneously, then we can do suspension laryngoscopy, and the rest is almost the same. Then, if we move a bit higher to a bit different technique, where we get the high flow, and you'll all try that in the workshop, you know, we can go up to 70 liters per minute, and that does allow, you know, the high flow. Many of you use it at home, and it feels nice, as long as you don't turn too much up. This will allow brief procedures with suspension laryngoscopy, but only very brief. And it will allow a full glottic opening to be seen. It will allow balloon dilatation if we make a break, but we need 100% oxygen here. We cannot go lower for laser surgery. It has been tried, but that will result in a lower successful oxygenation and often a need for intubation. And if we have the high oxygen fraction, we will sometimes get an airway fire. So we have a dilemma there. So we cannot really go down in the oxygen fraction. And then when it comes to CO2 elimination, that's a crucial question. You know, in the beginning, some years ago, we called this THRIVE, the high flow nasal oxygen, because we thought there was a ventilation. But we doubted that. We took 35 patients, we gave them full anesthesia and new muscular blockade. We gave them 70 liters of oxygen per minute, and then we just waited. Took an arterial gas and transcutaneous CO2 every 5 minutes, or continuously, wait until the PaCO2 rose to 12 kilopascal, or the pH fell to 7.15. And this is what resulted. The apnea duration is on the x-axis. After a median of 25 minutes, the patient reached this severe acidosis, and the range was unpredictable between 20 and 45 minutes. So we could conclude that unpredictable respiratory acidosis will develop if we just give high flow nasal and do surgery. And our colleagues here from Bern, they did a very nice study where they used different levels of flows, and the result is that the CO2 increase is the same. So there is no ventilatory effect of the high flows as opposed to what was thought a few years ago. So it's not really useful for laser, and it doesn't give us any CO2 elimination, which is important, of course. And there's just now, a few months ago, published some cases with high flow nasal oxygen saturation 100%, but cardiac arrest due to severe hypercarbia. And another case, unconsciousness due to high CO2. So it's not to be taken lightly, and it will not allow a cough inflation. Then we have the jet ventilation, either supra-infraglottically. You know these two techniques. They will give either 100% U or 75% U of the vocal cords. They will allow balloon dilatation if you have a supraglottic. They will allow a mixture of oxygen so that we can go low in oxygen fraction for laser surgery. They will allow CO2 elimination so we get some ventilation. And the rest of the answer is this, and we still have aspiration risk. Then what about the common technique, apnea with repeated intubation? That is definitely possible. The question is to use a tube that's as thin as possible. And there you see in the middle, we've got a tube size 4.0, and that doesn't always allow ventilation, but it often does. The other one is the tritube, only 2.4 millimeters internal diameter. We'll get back to that. So this will allow us 100% when the tube is out and down to 45% when it's in. It will allow balloon dilatation. We could go down in the oxygen fraction. We will have CO2 elimination, but we will not have a cough in for the whole procedure. Then we can go so low in tube diameter that we can do some of the surgery at least. And there we got this beautiful tritube that you'll all have the possibility to try today. Only 2.4 millimeter internal diameter. And that's, of course, only necessary because of special techniques. So you had 3 lumina, interluminal for the ventilation, then for the pressure measurement, distal in the airway, and then for the balloon. And this is all we need, 15 liters of fresh gas. And then we can use the ventrain manually. So we have active inspiration and active expiration. So we suction the gas out of the lungs and inflate it again. Also called flow control ventilation, very gentle to the lungs. And this is during surgery. And nowadays we can even get a ventilator. You'll get to see and play with that during the workshop. And this is how it looks, suspension laryngoscopy with a small tube in it. And after surgery, you can see the tube is so small you can get away with a lot of surgery there. So if we use the tritube, we'll actually see 3/4 of the glottic opening. And this will not allow balloon dilatation. We can go down in oxygen fraction for laser surgery. And this will allow an inflated cough for the whole procedure. That's the only of the techniques we can have an inflated cough if we have a severe risk of regurgitation or for getting debris in the airway. And then what about front of neck airway access for this? That could either be a jet ventilation through the cryocytic membrane or an elective tracheostomy, which is often used here. And it gives us a good view of the glottic opening. We can variate the oxygen fraction, but we only got protection against aspiration if we do a wake tracheostomy and inflate the cough. Otherwise, we don't. Then we have something that we heard this morning, that ECMO is disputable when it comes to, for instance, cardiac arrest, but when it comes to airway, it's excellent, even in a semi-emergent situation. We just had one that was a brilliant example of this. So venous bifemoral ECMO is the way to go. It doesn't even need anticoagulant therapy. It allows 100% glottic opening. We can go down in oxygen fraction. And this is the only technique that doesn't demand an open airway. So it's useful for obstructing tumors in the lower trachea or around the bifurcation of the airway. But it will not prevent aspiration necessarily. Okay, so we got a lot of choices. But you may still ask, is that really all? No. We would like a technique that works for awake anesthetized patients without any device in the airway that allows an FiO2 as we want it, and that works in a physiological, better hemodynamic profile, meaning that we get less blood pressure fall when we give anesthesia, and can work for a prolonged period of time. And you're all gonna try that at the workshop. It is a cuirass ventilation, extra-thoracic cuirass ventilation. And I bring this, this is the cuirass. You know it from the Roman Empire, made of cow skin at that time, but made in metal as well, and now made in plexiglass. And this was the first time I tried it on. I remember it still because that was the first time in my adult life that I didn't even have to breathe. So it's so relaxing. I was almost falling asleep. I said, wow, we need to develop that for airway surgery. And this is how it looks. So you can apply negative pressure, then you rise the thoracic cage, and you also get diaphragmatic movement, and with the positive pressure, it goes the other way, so it allows ventilation from the outside. And this is how it looks. This is our pre-resident. He is in our department, but he wants to be a resident, so we can use him for anything. Okay, so please hold it in place. He's willing to let us demonstrate. So like this. We put the cuirass on. Yes, and now we attach the ventilator that will create positive negative pressure in the shell. The blue tubing is for measuring the pressure in there. And then we put on the transcutaneous CO2 measurement, because that's a brilliant way to measure if ventilation actually is sufficient. And then, in this case, a nasal mask, because you can use that together with the gas supply from the anesthesia machine. And then, if we maintain jaw thrust, we have an open airway. We can do whatever we want to that airway, but we have to maintain the airway open, of course. Then, even nicer, which we use almost all the time nowadays, is to combine. So we put on the high-flow nasal oxygen, but with an air mixer, so that we can go down in oxygen percentage for laser surgery. And we can do that because we have the ventilator, which we don't have with the high-flow nasal in itself. So with this, it solves many of the challenges that I mentioned before. And due to the transcutaneous CO2, we can be sure that we don't reach the dangerous level that I showed you beforehand. So back to Hanne, the patient here. Looks normal, it doesn't look normal here. So mask ventilation, transcutaneous CO2, arterial line, we use that in the beginning, place the cuirass, start mounting the surgical equipment, suspension laryngoscope, and in this time we use the nasal mask, we use the high flow nasal most of the time, and then start surgery, and this is what we see. So you have the patient ventilated with only surgical equipment, no airway equipment in the airway. And you see how it goes. And there you see a totally unobstructed field for surgery that allows using multiple instruments during the same case without switching, without intermediate intubation. And so here we got 100% view of the glottic opening. We can vary the oxygen fraction. We just a few months ago published the first case series on this, even with a cookbook. So you actually go to the BJA, or you can go to the reference list and follow this cookbook. And if you take care of a few things, it will work. You combine with high flow nasal. These are our results. We used it for, among other, laser surgery. This is the CO2 monitoring. In the beginning, we replaced an arterial line, but then we made this study in the meantime, where we compared arterial gas with transcutaneous, and it's a very nice correlation. So now, most of the time, we only use the transcutaneous to monitor this. And actually, in this case, we only found a difference of 0.6 kilopascal maximum. We had, even at the end of ventilation, maximum 7.3 kilopascal, meaning definitely in the safe range. And that works, but we'll keep refining. I'll show you a new way of measuring the ventilation from the outside for the expiring, and you can also try that at the workshop. We put on some electrodes that will measure the impedance over the right lung. That means that when we put some, we create some kind of ventilation with the cuirass, because we cannot measure entire CO2. We have this device, and the curve will come up. Here you see every breath, it gives an impedance change, so we know breath by breath whether actually a ventilation is going on, which is very nice because we don't want no airway obstruction. So we have ventilation, we can change the FiO2. It will still demand an open airway. And in this series, we had up to about an hour. We have had longer cases now. And what about the surgical conditions? In all cases, the surgeon spontaneously reported we never had so good conditions. So, yeah, shortcomings, yeah, no real experience in morbidly obese, but John, who's also here, who will demonstrate it, has from intensive care some good cases with obese patients, actually, we haven't had for surgery. And then, very important, if you have floppy tissue, for instance, you have a papilloma or something, you have to be careful to keep the airway open, meaning place a suspension laryngoscope open so that early in the case, so that the airway will stay open. And yeah, so we can tailor this to our patients. All of these things we can tailor to our patients. And that's actually one of our main messages. And now we will have a small change in the program, because now Michael will present the workshop setup while I find Chris's presentation. So, and that's a surprise to Michael, but we are used to working like this. So you just go through the stations here. That's all, and so that you can make people look forward to.
I most certainly will.
Yeah, thank you very much. Very useful. You can tell one of your not the one about being in Norway.
Look at this. In the workshop, we have 6 or 7 stations, depending on how you look at it. One with the ultrasound identification of the cricothyroid membrane. One with front of neck access. One with cuirass ventilation. And Thrive, or at least high flow nasal oxygen. Bloody, bleeding airway, 2 of them, one with what we call the easy part, and one with the difficult part. What is special here is that in all the stations you will have the opportunity to try things yourselves. There will be a lot of blood, a lot of difficulties, but it will go very well in the end. We have a confined airway, confined space airway management station, an indoor section and an outdoor section. It's meant to be that the indoor section you try different tools, and then you go outside for a more realistic scenario to experience that it is probably a little bit more difficult intubating patients in this scenario than you are used to back home. So, a good idea will be to bring a jacket to the workshop, because you wouldn't want to miss the outdoor session conducted by Jeltje. Very good idea, Søren. Søren reminds that you should not only bring your jacket, you should also bring, if you want to, a large beer.
Okay, so as I was saying, the salad technique, suction-assisted laryngoscopy and airway decontamination, a proactive, stepwise approach to manage the contaminated airway. I was taught that suction is something that's important to have around, right? But I wasn't taught to use it actively. So this is a video from Mexico, or as we call it in Albuquerque, Old Mexico. And hopefully this will show some examples of an airway we are probably all familiar with, which is a contaminated airway. Just click, see if the video will play. Yeah. So this is a cardiac arrest. We often encounter soiled airways in cardiac arrest. Sometimes, or some studies have shown that upwards of 40%, to me it seems like 100% of the cardiac arrest airways I arrive at are soiled. So here a junior resident is attempting to intubate the patient. The airway is obviously significantly contaminated by blood associated with the chest compressions, and the airway is presenting a lot of difficulty. There are a lot of cuts because there are pauses as they kind of recalibrate the approach. So we're using video laryngoscopy here, and we are about to encounter one of the primary pitfalls associated with video laryngoscopy, which is as soon as the lens becomes contaminated, right, especially if we're not using a standard geometry device, we have to abort the attempt, reconsider what it is that we're doing. So with the salad technique, we're going to practice proactively using suction to help us manage the airway, both as a means of mitigating the contaminant and as a tool for airway management. So now someone who has experience with the salad technique and has practiced on a vomiting mannequin at some point is going to attempt the intubation. And you'll see that when they introduce the laryngoscope, they're staying high away from the contaminant, and they're going to put the catheter, which we can see here, out in front of the laryngoscope to actively manage all of the contaminant that's coming up as the airway attempt is ongoing. And now what's happened is that the catheter has been withdrawn from the mouth and reinserted opposite the laryngoscope. So we're going to leave the catheter in place throughout the intubation attempt. The catheter is going to sit in the hypopharynx to continuously suction out whatever gastric contaminant is coming up, whatever blood is coming up, and that'll allow us to maintain a clear visualization throughout the attempt. So what does airway contamination do? It negates ventilation by mask ventilation or supraglottic airway, right? It neutralizes our attempts at apneic oxygenation, and it essentially negates all forms of endoscopy. So salad manages airway contaminants while assisting the rescuer in placing basic and advanced airways. We are proactively addressing the contaminated airway. We're also creating space to utilize our airway management devices. This is not just about intubation, right? When we've seen supraglottic airways fail, right, that's often because we have not adequately created space to introduce the device to seat it in the hypopharynx. So I was taught that you can just stick your thumb into the mandible and pull it forwards, but you can also use a suction catheter in order to create that space to introduce the device. So specific steps of the salad technique. And what I'd like everyone to do is just mentally rehearse this so that when we get to the station, you can actually practice this hands-on. It'll be like, it won't be the first time you've done it. It'll be kind of the second time you've done it. So you're about to intubate. You have your laryngoscope off to the left. You're holding a suction catheter in your right hand, ideally a larger bore suction catheter, because Yankauer catheter was invented by Dr. Yankauer to dab blood out of the surgical field during a tonsillectomy. That is not what we are using suction catheters for in emergency situations, right? So we're going to hold the catheter overhand and insert it into the airway to start to suction out any contaminant that's in there and to proactively distract the mandible in order to create space to introduce our supraglottic device or our laryngoscope. Once we have the catheter around the base of the tongue, distracting the mandible forwards while providing suction, we'll now insert our supraglottic device or our laryngoscope. Then we will manipulate the tissues of the tongue and the hypopharynx to maximize our view as we get the laryngoscope into position. So instead of having to kind of scoop and incrementally move around the base of the tongue with the laryngoscope, we can really use the catheter to maximize that space in the vallecula, in the hypopharyngeal space, in order to really seat that laryngoscope exactly where we want it. Finally, we will withdraw the suction catheter from the right side of the mouth and reinsert it to the left of the laryngoscope, parking it in the hypopharynx. And now the catheter will stay out of our primary visual field, but it will sit in the hypopharynx throughout the intubation attempt. So even if the patient continues to regurgitate, even if the patient continues to bleed, whatever contaminant is pooling in the hypopharynx will continuously be suctioned throughout the attempt. So here is one more video of a gunshot wound to the face where the salad technique is employed as the initial airway approach. Oh. I have to go back. Mouse is getting there. Warmer. Warmer. Red hot. Okay. So a lot of blood pooling in the hypopharynx. The catheter is way out in front of the laryngoscope, and it's being used to distract the mandible and create that space. In this attempt, they did actually leave the catheter in place on the right side of the mouth, but it is in the hypopharynx, continuing to suction any blood that is pooling. The bougie is introduced easily. The tube is slid over the bougie, and in seconds, what could be a nightmare airway scenario is mitigated by proactively and deliberately using your suction instead of reaching for it once you've realized you have a problem. So I will give the microphone back to Michael.
Thank you, Chris. Thank you very much. Okay. Time for a beer and then workshop and discussion and questions and feedback and good ideas to work on. Thank you very much.